Thank you so much. My name's Jackie Dunkley Bent. I'm Head of Maternity, Children and Young People at NHS England, and it is a great time. It's an exciting time to be a midwife. I've landed at NHS England at the time when we have one of the biggest policy drivers for transforming maternity services, Better Births, the report of the National Maternity Review. And for those of you that are as old as me or a little bit older, you may well remember the excitement in the nation around the time of the publication of Changing Childbirth. Better Births far surpasses what Changing Childbirth could ever achieve, because now maternity services has key people at NHS England who will ensure that policy will be turned into practice. It will not be a document that sits on the shelf. So in my day job, I drive forward Better Births and the recommendations therein. And in particular, I always seem to land the big challenges, and that is continuity of carer. So for those of you that know the recommendations in Better Births, one of the recommendations is ensuring that most women will have continuity of carer. And that is a huge challenge for our maternity service. But there are resources and support to help us to deliver that. So that's the day job. What many of you may not be aware of is the fact that supervision is cited and is an integral part of the recommendations of Better Births. And another big ticket item that landed on my desk when I started at NHS England was the supervision challenge. And so I'm going to talk to you in particular about that and leave continuity to the side just for the next 20 minutes or so. So I think most of you will be familiar with the reason why, or one of the triggers for, the demise of statutory supervision. A very sad time for most, but it's important to recognise the triggers that occurred along the way to influence where we are today. And there were a group of courageous families who brought the attention of some challenges regarding statutory supervision and what it was meant to achieve, but unfortunately there were things that it didn't achieve, and there were some challenges that resulted in difficult times for women and their families. Also, if we think about the other challenges that happened around that time and the impetus for change, the Kingsfond Report, all cited in the literature, all easy for people to search and understand. The Kingsfond did an extraordinary view and advanced recommendations regarding removing regulation from supervision, and to canter through some of the documents, the NMC accepted the recommendations and wrote to the Department of Health and asked for a law change so that statute would be removed from supervision and there would be one regulator and one regulation process, and that would be the NMC. So the Section 60 order ensued, and on the 31st of March this year, statutory supervision ended. I know what that meant for you. When I go back to base, I'm scheduled for 4 clinical shifts a month. That gets bumped about 70% of the time, sometimes 50% of the time, but when I am on the ground, I can see what that means to you, and also thinking about the challenges of those people that were in full-time posts at a national level. So the local supervisory authority, midwifery officers, the LSAMOs, what that meant to them, and their support staff, the support midwives and the administrative support that kept us afloat in the North, Midlands and East, London and the South, not to mention the islands, and also the same applies to the Celtic countries, Wales, Scotland and Northern Ireland. The change happened, and it had to happen. The NMC accepted those recommendations, and the 4 countries were tasked with developing a task force to develop the new model of supervision for that respective country. So for England, the Chief Nursing Officer for England, Professor Jane Cummings, was the Senior Responsible Officer, the SRO, for that change, for the development of a new model, and there was a task force that I led to develop the new model of supervision. So we reached out to you, and we reached out to women, because we wanted the new model to have an empirical evidence base, number 1, but number 2, to be reflective of what you feel, what you felt that the new model should include. There were some specific things that we had to adhere to, and they were that there wouldn't be investigations or anything to do with an investigation integral to the new model, and the new model would be different to the old. So the engagement, approximately 2,400 responses, and when you think about the approximately 47,000 midwifery registrants, that's a drop in the ocean, but nonetheless, it's a sizable amount. So we used several different platforms to collate the information that we have today that's informed the new model. So what did you say? And it's interesting, we ran a thematic analysis on all the information we received. And I have to say, my mailbox, despite the fact that we had a repository on the NHS England website scoping the views, we were out to conferences, there were questionnaires, surveys, etc. I also had a plethora of emails. So my mailbox was always heaving at the seams. And it was interesting, some of the questions and challenges that I received personally, and they related to, Jackie, why are you taking supervision away from us? And actually, I wasn't. There's a story to be told in terms of where this journey started. And also, there were concerns about midwives not being supported if supervision wasn't in the system. But very specifically, we monopolised on the items on this slide that talk about midwives needing to be supported, empowered, that there were the Y and Z generation midwives who shared very openly that they didn't know how to advocate for women, because they would refer women who wanted care that was atypical to the supervisor of midwives. They never actually provided that advocacy piece. They referred women on. And you know, we can all think about that and be negative in some regard. Why can't they? They're NMC registrants, they should be able to do that. But our infrastructure that we created that situation whereby junior midwives, some junior midwives were not able to advocate for women in their families. So they wanted that to be built into the new model. What did women say? Very interestingly, but unsurprisingly from my perspective, in one of my past lives, I've supported women who are pregnant as a result of rape, asylum seekers and refugees. And interestingly, you know, if I hadn't have said to them about supervision of midwifery, they wouldn't have known who a supervisor was. Similarly, today, there are women who do not know what a supervisor of midwives is. So when we reached out to women, that was the #1 response, which tells us a story about who supervision was for, and other things you can see from women. So you said, women said, and we did. And we came up with the A-Equip model, advocating and educating for quality improvement. When I think about our wondrous maternity service today, when I think about the policy drivers, when I think about the Secretary of State's ambition to ensure that we are the best maternity providers in the world by driving down our perinatal mortality and morbidity, when I think about better births and its ambition, when I think about all the things that we're trying to do to ensure that women and their families have a safe, personalised and good maternity experience, we had a look at what we had a look at the evidence base, had a look at the supervision models that exist today, took a good deep dive at the available evidence, and we came up with A-Equip. The ultimate aim, as you can see, is to ensure that quality improvement is an integral part of everybody's business all of the time in all parts of the system. It doesn't belong to one person. If the quality is good, women will have a good experience. So looking at that model, it takes its lead from Proctor's model, but also the restorative clinical supervision function of this model. It's one element, has an empirical evidence base behind it, and that promises to ensure, if it implemented appropriately, increase in job satisfaction, improved attrition, reduction in stress and reduction in sickness, amongst other manpower and workforce standards. So that function has an empirical evidence base behind it if implemented properly, and it carries a degree of training. Taking note of what midwives and women said, there is also the education and development perspective, which you'll all be familiar with from the statutory model, and also the monitoring and evaluation. The personal action means that everybody has a responsibility, personal action for quality improvement. Whether you have a quality improvement methodology expert in the trust or not, whether you have a governance lead, a risk midwife, whatever we're choosing to call these people, everybody has a responsibility. The ward clerk, the receptionist. When I think about the narrative that we plough through to run the thematic analysis from midwives and women regarding personal action, I thought about that story when one of the presidents, I think it was Nixon, I'm conscious that I'm live, so forgive me if I'm wrong, went to NASA and saw the janitor in the, oh, somebody's nodding, so I've got the story right, in the entrance to the building, and said, "What do you do?" And you know, the American way, shoulders back, chin up, that sense of pride. "Mr. President, I am responsible for putting the man on the moon." And when we walk into our maternity services, how amazing it would be if that cleaner, one of the most important people within our maternity services, said, "I am responsible for ensuring women and their families have best, safe, personalised care." So thinking about quality improvement, it's all our responsibilities. So just a clarity check, because I still receive emails today, not so many now. Who's going to do the investigations, Jackie? Just to be clear and reiterated again, what the new model does not include. So to develop this new model, we had pilot sites because we wanted to develop some kind of evidence, a little bit of evidence, to influence the development of our new approach. And we had 50% of maternity services submitting an expression of interest to be a pilot site. Such was the appetite to test the new model. Sadly, finance dictates, so we only had 7 pilot sites, but we tried to spread them across the country, and we also had an independent social enterprise one-to-one practice that also piloted the new A-Equip model. Within those pilot sites, there were PMAs, professional midwifery advocates, and again, that name came from you. The professional midwifery advocate is the new supervisor. And as you can see there, and as we've taken the lead from DH guidance, we need to protect and acknowledge that there needs to be education and training to underpin these really important roles. So for those that have completed the POSSUM course, the Preparation of Supervisor of Midwives course, in the past, they would be bridged into the PMA role. So they would undertake a shortened education program, 4 days long. It would be owned by HEIs because we want to maintain a standard across England. And so that's the shortened course. It's a bridging program. The longer course is for people who have not undertaken the POSM course. Now, the reason why we decided to go with the bridging for those that had undertaken the POSM is because you said we want to be valued. We worked really hard to get our POSM course at degree level, at master's level. We cannot throw the baby out with the bathwater. This is significant. There is learning to be shared across from the statutory to the non-statutory employer-led model, and therefore we need that to be valued. So our Higher Education Institute colleagues worked tirelessly to ensure that we could do that. So that all culminates. The evaluation, I should say, was undertaken by Sheffield University, a very robust piece of work, and thank you to Sheffield for keeping us on our toes. They were hard-hitting in their critique, but we used that feedback to refine the model. So the early model, the A-Equip model, only had 3 functions. Because of the feedback from Sheffield University, we concluded and now have 4 functions within that model. So Sheffield University advanced recommendations, we responded, and we produced national guidance. We learned from our pilot sites and we produced national guidance. I would commend this document to you. It can be downloaded from the NHS England website. It isn't a hard read. I have empathy with documents that you download. I download them too. And when they're too huge and too laborious, I only get maybe to the first page, the foreword, and maybe the summary, the executive summary. This one is an easy read. There is a section that has case studies that people can identify with. At the beginning, it talks about the background, why we're here today, the development of the model. It goes on to advice for HEIs in terms of the bridging program, advice for commissioners. Yes, we have advice for commissioners because this model is included in the NHS standard contract. If you didn't know that there was an overall contract for the NHS, you do know now. I read that for the first time in my entire career when I was working toward developing this. And it was a hard read, I have to say. I don't know whether anybody else has read the NHS standard contract, but I did. And I read that because I needed to ensure that we had some levers and incentives in the system. Some levers that would make, influence, empower our maternity providers to make sure that this was a reality. Because in the absence of statute, you told us, I kind of knew, but you told us that this will not be implemented unless we have some levers and incentives because of the financial challenge. So it is firmly embedded within the NHS standard contract, which means that if it's not implemented, the provider will be in breach of contract. So at the moment, and I'm coming toward the end of the presentation, at the moment we have committed higher education institutions, our universities that provide our education, to deliver the shortened and the long programme. We also have support from Health Education England, who have worked up with Lead Midwife for Education, Tony Martin, a e-learning resource. So there is an e-learning resource that everybody in England and the islands can access as a precursor to undertaking the bridging or the long programme. And we now have funding assistance. That's just the spread of the HEIs that are planning on providing the education. But what I will, and that's the e-learning module, so take a look at it. The website link is there. Even if you Google it, it comes up as one of the front runners on the first page. So an e-learning package to, number one, get you to have a look at what A-Equip is all about, what the PMA role is all about, but secondly, for those that are going on the bridging programme, to give you some pre-course reading. One of the big challenges, I would say, I've mentioned this in terms of how you become a PMA. One of the big challenges has been finance. For Better Births, it's a pleasure. I'm looking at Sandra. I didn't realise she was going to be there. Sandra's one of the most important midwives in England, who's working on Better Births. She's nodding her head with me. But what I find really inspiring about implementing Better Births is there is a huge pot of money, and we're talking about millions, to be able to implement Better Births. That's why it won't go away. Supervision is a work stream of Better Births, or one of the working groups. And therefore, we have a commitment from Health Education England to provide education, or rather pump prime universities and providers to train PMAs. This offer's on the table now, it's being worked up. So all maternity providers in England will have an offer on the table, a financial offer to support their midwives to become PMAs. And lastly, just a shout out really to somebody called Jason Westwood, who's a program manager for ensuring that AEQIP and the PMA role is rolled out across England, and inviting the islands to take part too. And he is working tirelessly to make sure that happens. Where we run out of money, we go and find more. We're committed to making this happen. Naturally, with any change management, we have the people that are first past the winning line. Then we have the fast followers, and there are some of you that are sat on the fence waiting and watching to see what happens. And I believe those that are sat on the fence will have a taste, think that it's good, and they will join the majority, and we will have PMAs and AEQIP across England, and more importantly, we'll have midwives that are empowered to provide the best care for women and their families. Thank you. Thank you.